the past week, we have seen a rapid escalation of cases of COVID-19.
Could this be something that spirals into a large lethal pandemic?
World Health Organization declared the outbreak an international public health emergency.
This is like a flu on steroids.
Throughout history, healthcare has been delivered in person. However, cost, convenience, and geographical barriers often pose challenges for patients to access healthcare. So many patients are not able to see a doctor or healthcare provider.
Mental health is at the core of our humanity. It enables us to lead rich and fulfilling lives and to participate in our communities. But the COVID-19 virus is not only attacking our physical health, it is also increasing psychological suffering. Grief at the loss of loved ones, shock at the loss of jobs, isolation and restrictions on movement, difficult family dynamics, uncertainty and fear for the future.
Okay, this is Gloria Starr Kins of Society and Diplomatic Review. We are a group of magazines and a media company. We are accredited to the United Nations, and I'm hosting with my partner in this type of media. His name is George Wen, and he is the president of his media company, and it is accredited to the United Nations also as a very important foundation, and accredited to ECOSOC. This is very high rank. George, say hello.
Hello, everyone.
So, now, the next ones we're going to talk now are Dr. Harry Glorikian, and he is going to talk with Daniel Laroche. Do you have Daniel Laroche? Where's Harry?
He's here.
I'm here.
Okay, so we're fine now. So you two guys can start the chat, and you can, Dr. Laroche is very, very involved with eye care, which I well understand, because with the need for eye care all over the world is very key. And Dr. Laroche, do you want to begin with the discussion?
Sure. Is there any particular direction you want me to go? I'll start from what my usual spiel is from my patients. We have the COVID-19 pandemic right now. It's very important people around the world wear masks when they go out and eye protection to protect, because at the hospital we all wear eye protection and masks because people can cough, and when they cough, droplets can get into your eyes. There have been cases reported of conjunctivitis as an initial presentation for COVID-19. Don't touch your mask, okay? Don't touch your eyes in that respect. So that's one. For the elderly population at 60 and up, we use telehealth. We use mobile phones to do telehealth communication. A lot of times patients do not need to come into the office. For example, if someone has a bloodshot eye, we can see that over the video and reassure the patient that's not serious. If they have a bump on their eye, like a sty, we can do that by video, and then we can send the antibiotics to the pharmacy for that particular patient.
This is also World Peace TV, and this is also Society of Diplomatic Review interviewing, and I'm adding it in because it's important to plug in, because as this goes worldwide, we want to repeat again. This is Dr. Laroche, Daniel Laroche. And if I'm correct, Dr. Laroche laments that there are not more Black American doctors in the United States and maybe in the rest of the world, but that is one of your mantras, and I wanted to mention it.
May I address that, what you just said? In the United States, we have 41 million Blacks. Okay, in my specialty of eye surgery, there's only 400 Black ophthalmologists.
Right.
Okay, with the other 18,000 ophthalmologists, there's a huge maldistribution on the East Coast, on the West Coast, and a shortage in the South. And because of the segregated society that we still have with residential space, there's a shortage in Black communities throughout the country. Now, cataract, glaucoma, diabetic retinopathy are leading causes of blindness. The rate of blindness from glaucoma is 7 to 10 times higher. So we need a lot more Black physicians to be trained to address the healthcare disparities that we're seeing with COVID-19. There's a tremendous shortage of Black physicians. And so we need to train more Black doctors to help meet the needs of the communities, to help address pre-existing conditions and blindness and diabetes and high blood pressure.
This is a very important point, Doctor, and this is important not just for the United States, but all of our health tourism from the Caribbean, from Africa, who come here. So I wouldn't say you are unique, but you're from a special elite group. Now, Dr. Shah, please.
Hi, Dr. Laroche, Raj Shah. Nice to meet you, and particularly during COVID, and as you mentioned that virus transmission may occur through the eyes, conjunctiva, etc. Is there any easier way, or is there any way you have come across where we can remotely take care of those patients who have glaucoma or retinopathy or something happening to that extent?
Well, there have been some progress with artificial intelligence where fundus cameras can take a picture of the retina of the eye. And just based on the picture of the loan, they can tell the age of the patient, whether or not the patient's a smoker, whether they have hypertension, whether or not they have glaucoma. This is early stage technology that's very promising, that will really allow us to triage care, to really just provide care that those that's needed and lower cost options for screening. So that's being worked on right now. There's some pilot projects in Kenya, Ethiopia, Canada's working on it. We're working on it here in New York City. Columbia University is working on it as well. So for artificial intelligence and telehealth, that's going to be, it's in process right now, and that's going to be integrated further and further as we get more along with that.
Patients don't go to the doctor if there's nothing wrong with their vision, and they would, and it's impossible to take a good picture. So patients coming to general clinic or general practice, they would have it, their picture taken, 24 megapixel picture without dilating pupil. It was so successful that in first 3 months they did 500 patients, which they didn't do 500 in previous 5 years. And that was written up in Forbes magazine in 2016, our new approach. And similarly, I'm also looking, if you are aware of, where you can remotely or non-invasively, you can do glaucoma, because glaucoma and diabetic retinopathy are the two biggest causes of blindness that we can, and early intervention, we can prevent it. So if there is something on that front, it would be a great help in eye diseases. And I have worked on telemedicine for the last 25 years, created my own system, which is not only just the video consult, but use the devices. Of course, I don't have the eye devices, but the otoscope for ear exam, nasoscope, general ear, nose, and throat examination, my own specialty being cardiology, listening to the heart and lung. And this is something we do live during the video conference. It's not store and forward. So this is something that I have worked on it and put this in effect, used it for insurance company in Philadelphia. And so that's my take on telemedicine, and it's phenomenal to know how you would be working on glaucoma.
Yeah, well, my algorithm for glaucoma has changed. Currently, the standard of care is to start with eye drops to lower the pressure. In patients over 50, in my practice, the leading cause of glaucoma is the enlarging lens in the eye. The lens can increase by about 30 to 40% with aging, okay? And what that does, when it gets larger, it compresses the canal that drains the fluid, and that increases the eye pressure. The mean normal eye pressure in the eye is 15. The mean pressure in patients with glaucoma is about 18. And that's when I tell people, make sure you get your eye pressure checked. If your eye's pressure is 15, that's okay. If it's 18 or higher, then we have to look at the drain of the eye. We place a lens on the eye to actually look at the drain to see if it's getting blocked off or pigments blocking. If that's the case, I recommend early cataract surgery. So with your tools that you have there, checking the eye pressure and checking corneal thickness, that's something else that would be great to do in terms of telehealth and telemedicine.
I suggest that you doctors exchange coordinates and you exchange emails. And as far as the emails, because we have an audience who might be interested, as you know, we're in New York City, we're a diplomatic magazine accredited to the UN. There could be many diplomats who would want to visit you who come in from all over the world. Dr. Shah is not far away. He's in New Jersey. So you two should exchange at least your emails. Give us your email because even our audience might want your email, sir.
Sure. My email is dlaroche, Laroche, MD @AOL.com. My website is www.advancedeyecareny.com. And my YouTube page is Dan Laroche, MD, and I have glaucoma videos and surgical videos on my YouTube page as well.
Thank you so much. That's Dr. Daniel Laroche.
Yeah, no. I mean, it's an area now that's going to grow dramatically because of these changes.
Yes.
And there is actually one artificial intelligence diabetic retinopathy scanning system. I just can't remember. Oh, it's a company called IDX-DR, which is the company that makes that available. And the other company to keep an eye on is Google's DeepMind. They have an optical scanning platform that can do 50 different eye diseases in less than a minute. So you can see how technology is going to make a dramatic impact on how we manage patients and patient care. So I think that you've been in it for a long time, but now that the reimbursement is there and the regulatory is open, it should be easier to have people embrace this and take it forward.
Good question, Deep. Those are the two most important barriers we had was reimbursement and technology, the cost of technology, which is coming down and down and down. That makes it easy. And finally, awareness. I mean, pre-COVID, I'm sorry to say, 17% of doctors even knew about they can use telemedicine to take care of patients. Now it is almost 100%. Likewise, patients, maybe 50% of patients were aware that they can see the doctor, but now it's almost 100% thanks to COVID. So this thing has really evolved so rapidly in the last 6 months. So I see a very bright future whereby we can deliver the care at a remote place. We can significantly increase our reach to particularly rural area, people who can get to the doctor for whatever reason, and not just only needed in the United States, but all over the world.
Yeah, no, definitely. And I can see that, and I don't blame the doctors, right? If you're not going to get paid for something, it's hard to run your business to do it, right? But now that CMS is reimbursing telemedicine visits at 100% of an in-person visit, there's no reason not to do it. I just had a general checkup 2 days ago with my primary care doctor, and it was all by FaceTime.
But we need to go 2 steps beyond that, which we did 10 years ago, and that is, doctor still needs to examine the patient. Listen to your heart and lungs, do the examination, take the vitals. Most of the medical problem can be handled by maybe 60-70% just by FaceTime. But remaining part, for improving the diagnostic accuracy, you need those. And those devices have to be affordable by patient, because in remote care, those devices have to stay with the patient, because if their vitals are being measured. So my take has been
the interesting thing is, I don't believe that it's going to be the medical device companies necessarily that cause that price shift. I think it's going to be the technology companies like Apple and Amazon and other companies like that that are going to drive down and make this technology more widely available.
No question about it. They are the one, they have the resources, they have the research, and they can do it. So we need that technology to bring down I myself, when I first looked at this system in 2001, the stethoscope, electronic stethoscope cost $3,500.
Right.
Today you can buy it for $250 to $500. It needs to go down to $50. Likewise, blood pressure instrument, when I began practice 50 years ago, cost $500. Only clinics and doctors' offices and hospital had it. Now at $30 and $40, every household has a blood pressure equipment, and we can detect. So it is the technology, it is development. There you go, see? So it was phenomenal a shift, and I don't want to say that curse on mankind is a blessing in disguise, but this really brought to the surface and focus on how additional different way we can provide care, and which is a remote care. And that's
COVID is a horrible disease. It's there's been a lot of people that have suffered from it. I think for the next 3 to 5 years, we're going to see residual issues from COVID, from cardiac issues and other issues that are going to creep up. However, by it changing the regulatory landscape, by it pulling forward technology, I think it's moved everything forward. Like I said, in some areas 5 years, in some areas 10 years. Sooner than it would have had we let the system.
Oh, it would have never come to the focus and limelight. So.
I would like to make a comment, Dr. Shah, what you said about visiting a doctor. At my age, the French say infâme d'un certain âge, which means don't ask, but I'm up there. What you said, though, is very key. A doctor must at least meet the patient and know the patient, know their brain, know their feelings and where they want to go. For instance, if I go to a doctor for the first time and you're talking to a lady who's 92, working still at the UN, doing interviews, arranging events as I'm doing here with you and Dr. Shah, and also with Drew Hingorani. What is needed is you need to feel the doctor knows you, and then you can zoom in here and there. But you have another problem. How, in our age, with all of this technology, can we use it? I mean, I'm lucky if I can use a cell phone. So I think one of the things that are needed is that we know our neighbors, we know the people in the building, the elevator men, to know whether they understand this technology or not on an emergency. And that would be very helpful, because Saturday, Sunday, there's no doctor in the world you can reach. You get a telephone service. And the telephone service isn't even adequate because they couldn't care less. So some way to structure that when this technology is available, how can we achieve to harness it for ourselves? That's my question.
I think you're going to see technology as it blends into everything that we have. It will be interconnected, and it will do things sort of automatically. So you can imagine I'm wearing an Apple Watch, and I have a wireless scale, and I have a wireless blood pressure cuff. And as I take these measurements as I would normally do, and it doesn't require any technological sophistication to step on a scale or for the ring to take my body temperature, that the Siri or the Alexa that you might have at home would then say, how are you feeling today? I noticed that your temperature was up. And you could interact with it. And it would, as a chatbot, gather information and create a holistic picture about you that in reality, that system would know more about you on a momentary basis than your doctor would, because they only see you once a year. Now, it could communicate that information to your doctor so they have a better picture. But as opposed to me going to my doctor and saying, it hurts right here, but it only hurts once in a while. This thing is looking at me 24 hours a day, 7 days a week. and creates a longitudinal view of my health. So if something goes wrong, it actually registers, as opposed to that, you know, when you take your car to the mechanic and you say it's making a sound, but it's not making it right now. And so it's very difficult to diagnose what's wrong with the car when it's not making the sound at that moment. But if I'm wearing this watch and it's taking my heartbeat 24 hours a day, 7 days a week, if something goes wrong, it's going to know it.
Also, you wrote a book, and the book is available. Do you want to tell us about the book? And that
sure.
would be nice.
It's called Moneyball Medicine. It's called Moneyball Medicine, thriving in the new data-driven healthcare market. It is, it's about how data is going to change all aspects of healthcare, everything from telemedicine, as we've been talking about, to cancer care, and how big data is going to make an impact on managing patients, and how the United States is trying to move from a sick care system where we only do something when you're sick to a healthy care system, which means keeping you healthy. And the only way to do that is by using technology.
They created the things in 3 hours.
Yeah.
That's the magic of technology.
All these vaccines and everything we're working on are being driven by the data that we got originally.
Right. Awesome.
Could you tell us some of the things you're working on for the future? That would be nice to know.
So my main job is I'm a venture investor, so I invest in a lot of different technologies that are coming down the road, a lot of therapeutics and a lot of data-driven oriented technologies that are in the space. But you can see that the next level is going to be technologies that incorporate data, AI, and can sort of help physicians as well as help patients manage either the data that's coming to the physician so that they can manage the patient better, or the patient manage themselves better. Some of those technologies can be the AI looks at an X-ray or an MRI and highlights something for the physician to look at, or changes the order because there's a long list of images that a doctor needs to look at every day. And what if the number 50, that person has a bleed in their brain? That one goes to number 1 because the machine determines that needs to be looked at first. Or how a patient, as I said, if information can go to a patient to nudge them to take that extra walk or to take their medications. Or I was explaining to someone yesterday, imagine you could have an inhaler that has a GPS chip in it, and you're in Los Angeles where the weather is bad. In other words, there's a lot of smog. Smog and asthma don't get along. So the app comes on and says, before you leave the house, take a puff of your inhaler. And so if you take a puff of your inhaler, you would avoid potentially having an asthma attack and ending up in the hospital. So it's just that little technology letting you know that the air quality where you are is bad and that you should proactively take your medication can keep you out of the hospital. So you're healthy and happy, and the insurance company is happy because they're not having to pay for you ending up in the hospital. So there's many different examples of how technology is being assistive to helping us be healthier.
Oh, I'm for last 40 years I'm sold on bringing technology or leverage technology for healthcare delivery, and that has been my passion. And with my own resources, I've created the system, and I'm trying to bring this to the mass use so that patients can be served. So nice to know you, and if you are in that space, I would love to connect with you.
Yeah, you should both exchange your emails and at some point all your coordinates. And this is the whole idea of this program, is to create continuing relationships. even what you were talking about biotechnology. Now they're going to have vaccines. Are you going to recommend we have the vaccine? Which one? Coming from what country? We're going to need both of you. And so I am hoping that you will both, why not exchange at least the emails now? And if you permit me, Harry, I'll give your cell number to Dr. Shah, and then he can be in touch with you. That's what our media company hopes to achieve. Now I have Drew Hingorani. Drew is a family I know for 30 years. He's a chip off the old blocks. He's not a doctor, and he's in AI technology, every way and shape and form. So he may have some questions.
Hi, Harry, nice to meet you.
Nice to meet you too.
I'm with a company called AI Blockchain. We're an Amazon AWS partner for 5 years. We started 6 years ago. We were given a hospital lead a year ago where we designed a wire solution to simplify RVU agreements. Relative value unit agreements, the way that physicians get paid. So right now they're using Microsoft Word and Microsoft Excel to do these arrangements, how physicians analyze how they're going to get paid by the healthcare institutions or hospitals. We devised an app and a wireframe solution to get rid of Word and Excel to make it easier and simpler for physicians to realize how they get paid using a cloud compensation payment platform. And enabling this, it enables physicians to spend more time with patients. So I'd love to email you some more information on our patent and product and what we've done. We also handle big data for encryption, which I have a number of answers from my CTO who couldn't join us today, but you'll meet him eventually in the future.
Excellent.
Thank you, Dr.
Thank you.
Any comments? Any more from anyone?
I will text you my cell phone and email when Gloria gives me your cell phone number.
What about fundraising?
Excellent.
Great. Are you located in New York or?
No, I'm in Boston.
Boston, okay. All right.
On this aspect of all these new technologies, isn't there a need today for a lot of fundraising, or is it not that expensive or
no, there's a tremendous amount of money out there right now. I mean, there's an absolute tremendous amount of money sloshing around in the system. If you think, do you put your money in the bank and get 1%? Foundations can't afford 1% returns. Big institutions can't afford 1% returns. So there's a lot of money that's looking for higher returns, but if you want a higher return, it usually means a higher risk, which is investing in different technologies or different therapeutics, at least in the healthcare world. But I think you can see from the investments that are happening in technology overall, these are not small dollars that are moving around.
Thank you, Doctor. So now we'll close this particular session. If anybody, Drew, do you want to make a comment?
In terms of big data, I know one thing that my co-founder really wanted to stress is blockchain technology as a solution for big data and in terms of encrypting patient records. So that's something we could share with you all on a demo one day.
Okay. All right. So in this case then, Dr. Shah, do you have a last comment or anything you want to say?
The last comment I say is, technology world, we're going to need you to solve many of our problems, but when you create the technology, make sure that it doesn't increase burden on us like EMR did. Make it so it is easy to use, it's easy for doctors and patients to use, and it actually increases our productivity rather than putting so much of burden on us to produce the data for a different purpose. It should be, data collection should be by the way as we do the work, not the primary reason how EMR and other technology has come around. That's my kind of a little thing about technology, but I would only say for last 2,000 years, healthcare has been in person. doctor goes to the patient or patient goes to doctor, wherever they are, always in person. Now, for 100 years, we were doing telemedicine using telephone. Last 20 years, video technology has brought us a way to do audio and video. And I think we need to very quickly move to the next step, which is diagnostic, either with simple devices or more involved devices, but they all have to be more non-invasive devices using something like ultrasound or MRI, etc. So my wish list is like, can I have a pocket MRI? Can I have a virtual touch?
And now I want to introduce George Wen. He's my partner, but also the man behind the camera. And we'll be in touch with you. We're very grateful that you accepted this interview, and I hope you'll come another time with another group if possible. But George, everything that we're doing here with PeaceeverTV is also sent to China, and I thought you'd find that to be interesting. Have you ever visited China?
I have not yet. That hasn't, for some reason, that geography has not, I haven't ended up there, but I know that it's going to happen when all of this is over and we can go back to normal travel.
Well, let us know, because also Julia Liu is born in America. She's Chinese American, and she's my associate producer. Say hello.
Hi.
Hi.
Thank you again.
Thank you. Take care. Bye-bye.
Connect with you, with your tremendous insight into technology in medicine, which is my passion, and being a cardiologist.
That's the whole
Excellent
program. And if you get any ideas, or if you come to New York and we can do a program with you in person, we can follow up.
Yeah, excellent. I look forward to it. Thank you so much. Have a great evening.
Thank you.
Bye-bye.